The name of my capstone is Healing in Her Story, Adapting Narrative Therapy to Treat Strong Black Women's Schema Symptomology by me, Jamali, LCSW. Summary of the problems. The primary problem that this capstone project addresses is the overall lack of research in Black women's mental health and appropriate treatments. To be more specific, there are no treatments for strong Black women's schema. A secondary issue that this capstone will also address is the lack of research around how to use implementation science strategies in mental health private practice settings. Strong Black women's schema, or SBWS, is a psychological and social phenomenon in which Black women must display overwhelming strength and self-reliance while facing various forms of adversity. Dr. Cheryl Woods Giscombe developed a conceptual framework for SBWS that includes displays of excessive emotional strength, emotional suppression that often comes in the form of self-silencing, resistance to being vulnerable and acceptance of help from others, an intense motivation to succeed, which stems from fear of failure and perfectionism, and lastly, being a caretaker for others and not prioritizing self. SBWS can have positive implications, especially as it pertains to personal and professional accolades and outputs. However, the stress and allostatic load of SBWS can negatively impact overall health. An example of this is a study led by Zahara Thomas in 2022 that showed Black women are more susceptible to more advanced cellular aging than white women, white men, and Black men. The mental health consequences of possessing a high allostatic load can include depression, anxiety, and psychosomatic symptoms which can impact physical health, even on a cellular level. It is noteworthy to mention that SBWS is a survival response to the trauma of long withstanding oppression and colonization woven into America's cultural fabric. The research-informed intervention I chose is called narrative therapy. Narrative therapy, or NT, is an evidence-informed intervention popular with treating Indigenous people of New Zealand, Africa, and Canada. The NT approach centers on the client being the expert of their own experiences and therefore their own memories and stories about their experiences. It requires that the therapist help the client deconstruct their own story to externalize appropriate issues that impedes clients' behaviors and outlooks. For the purposes of this capstone, I utilize NT for 8 one-hour-long sessions with 7 Black women clients. Also, I adapted narrative therapy using womanism concepts. Womanism, not to be confused with feminism, is a term developed by the author Alice Walker, and it is a social, political, and cultural framework that centralizes race, gender, class, and sexuality as primary markers of women's lived experiences. The practice setting in which I did my capstone is my private practice. Just to define private practice a little bit more so we're all on the same page about what it is. The clinician is the sole proprietor and practitioner. I am the clinician. It is a small setting. The only stakeholders in a private practice are usually the clients and the therapist. I have a virtual practice, meaning I see my clients over Zoom, not in person. I only offer individual sessions, one-on-one sessions. All my clients in this study identified as Black women. And lastly, just a note about private practice. It's really difficult to conduct research in private practice for various reasons, but namely because of regulations around privacy for clients. I decided to use implementation science concepts and frameworks to track and guide the adoption of narrative therapy into my private practice. I selected to use the knowledge to action framework as an overall guide to implementation. Then I selected the COM-B as my theory of change. The COM-B theory suggests that behavior is affected by one's capabilities, access to opportunities, and motivation. I then utilized the theoretical domains framework, also known as the TDF, and the consolidated framework for implementation science, also known as the CFIR, to assess facilitators and barriers to the implementation of narrative therapy in my private practice. A needs assessment was taken with myself and my clients to find facilitators and barriers to implementation. The facilitators were my existing clients trust me as their therapist. Only a small financial commitment was needed for getting trained in narrative therapy, for me to get trained in narrative therapy. Since it is my private practice, there was no organizational or corporate red tape around implementation. And lastly, narrative therapy can be easily adapted due to its post-constructivist origins. The needs assessment also included some barriers towards implementation, which were clients' hesitancy to start a new form of therapy. Pre-implementation, I was not formally trained in narrative therapy. For the purposes of this study, I had to take on new clients. This meant that there was no established rapport or trust developed between me and these new clients. And lastly, there are no manuals or protocols around how to adapt narrative therapy to treat strong Black women schema. To address these barriers, I selected implementation strategies from the expert recommendations for implementing change, better known as the ERIC, and behavior change techniques, better known as BCT. To address clients' hesitancy, I selected the BCT of demonstration of behavior, specifically demoing narrative therapy with clients. To address the lack of training I had with narrative therapy, I selected the ERIC strategy of training the trainer, which meant that I got basic training on how to facilitate narrative therapy with clients. For the barrier of having no established trust and rapport with new clients, I selected the ERIC strategy of having educational meetings where I explain narrative therapy to clients. And lastly, I decided to develop educational materials around how to adapt narrative therapy to treat SVWS. Since implementation strategies are understudied in private practice, I decided to measure how effective demonstration of behavior and education meetings are with building the therapeutic alliance, primarily trust and rapport. I selected 4 scales to measure the effectiveness of the intervention and implementation strategies. The PHQ-SADS is a validated measure with 3 subscales. The PHQ-15, which measures somatic symptoms, the GAD-7, which measures anxiety symptoms, and the PHQ-9, which measures depression symptoms. The Stereotypic Roles for Black Women Scale, or the SRBWS, is a validated screener that measures self-esteem by using Black woman stereotypes. The SRBWS has 4 subscales that measure how one associates himself with the Mammy, Sapphire, Jezebel, and Superwoman Black woman stereotypes. The Giscombe Superwoman Schema Questionnaire is a validated measure for strong Black woman schema, and it uses Dr. Giscombe's conceptual framework, which is also its subscales. And they are, again, strength, emotional suppression, resistance to vulnerability, motivation to succeed, and caring for others. Lastly, the Implementation Strategies Questionnaire is a scale I created to measure the effectiveness of the implementation strategies of demonstration of behavior and educational meetings. All measures in this study are composed of Likert scales, and only the Implementation Strategies Questionnaire had an open response section for qualitative evaluation of clients' responses. The implementation research questions are also the subscales of the Implementation Strategies Questionnaire. There were 4 questions, and the first 2 measured how effective an educational meeting was with reducing client hesitancy and increasing trust with me. The last 2 research questions measured the effectiveness of demoing narrative therapy to reduce client hesitancy and increase rapport. The intervention research questions measured adapted narrative therapy effectiveness with decrease in anxiety, depression, and somatic symptom scores on a PHQ-SADS, adapted narrative therapy effectiveness with increasing self-esteem scores on a Stereotypic Roles for Black Women scale. I also developed questions to investigate the correlation between strong woman scores on the Giscombe questionnaire and depression, anxiety, and somatic scores on a PHQ-SADS. Implementation strategies outcomes were, the implementation strategies questionnaire, was distributed 3 times during 12 weeks of implementation. And I had 7 clients. The questionnaire was distributed during week 1, which is considered baseline, week 3, which is considered time 2, and week 12, which is considered time 3. Clients' baseline, time 2, and time 3 scores were not significantly different. Quantitative scores from baseline, time 2, and time 3 were all high. Time 2 had the highest mean score, and I think that's because I distributed the implementation strategies questionnaire right after doing the implementation strategies, and time 3 had the lowest score because it was the December holidays, and therefore sessions were a little bit more sporadic and inconsistent. Qualitative data indicated clients felt that educational meetings and demonstration of behavior improved rapport, trust, and decreased client hesitancy. The intervention measures were distributed and completed by my clients during week 2, which was the pre-test, and week 12, which is the post-test. These measures included the PHQ SADS, the SRBWS, and the Jamali Superwoman Schema questionnaire. As you can see, depression, somatic, and anxiety scores decreased post-intervention. Adaptive narrative therapy was statistically significant in reducing my clients' depression, anxiety, and somatic symptoms. There were also positive correlations between strong woman scores on the Jamali questionnaire and depression, anxiety, and somatic symptom scores on a PHQ SADS. However, it was not effective in increasing client self-esteem as per the scores from the SRBWS. These positive correlations indicate that possessing strong Black women schema puts one at risk for depression, anxiety, and somatic disorders. Key insights and takeaways in regards to the implementation strategies. There is potential for ERIC strategies and BCTs in private practice to be used to improve therapeutic alliance. Educational meetings and demonstration of behaviors enhance client-informed treatment. Strategies, or these specific implementation strategies, can decrease historically induced iatrophobia, which is fear of health providers amongst clients of color. Intervention strategy. Adapted therapeutic modalities using social and cultural frameworks can increase effectiveness of treatment for clients of color. Narrative therapy can be successfully adapted, specifically using womanism concepts. Assessing for strong Black women schema is vital in mental health treatment for Black women. And lastly, the positive correlations between strong Black women schema and some mental health symptoms indicate that strong Black women schema can negatively impact overall health of Black women. Next steps. Short term, I will guest lecture in the fall at 2 institutions, and I hope to facilitate some continuing education unit trainings for other clinicians. Long term, I'm hoping to publish my findings. I also want to learn more social and cultural frameworks and how to adapt evidence-based mental health treatments using them, and possibly teach a course around decolonizing therapy. But I don't want to see anything school related anytime soon. So that's like long term. Right now, immediately, I just want to graduate. And that is my presentation. Thank you so much for indulging in my work.